Still working on the errors with our renal students.
So again, I did my cancer on rhabdomyosarcoma. I'll probably refer to it as RMS or rhabdo since it's very wordy. So my patient was a peds patient, and I named him Snacks because he loves snacks. And after every treatment, every day, we'd give him chocolate or licorice, and he loves sweets and hot Cheetos and stuff like that. His primary cancer, again, is called rhabdo. His treatment site was a very large field. It was in his abdomen and pelvis, and he was labeled as a stage 3. Now, normally, for soft tissue sarcomas, they're graded by histology, so what the cell looks like, whether it's well differentiated, moderately differentiated, stuff like that. But in his records, I only found that he was a stage 3, and according to the American Cancer Society, it means that the tumor appears in an unfavorable site, whether that be bladder or prostate. And for Snacks, we think it started in his prostate, which is very weird, especially for a 12-year-old. What can apply is the tumor can be smaller than 5 centimeters with no lymph node involvement, or larger than 5 centimeters with or without lymph node involvement. And so what is rhabdomyosarcoma? It's a soft tissue sarcoma, and it is a very rare cancer. It accounts for less than 1%. Specifically, it usually forms in the skeletal muscle and favorably in the hollow organs, such as the bladder, the uterus. And it can occur in any age, but unfortunately, it likes to occur in children. And because of where these cancers can occur, they can grow very large before it's actually discovered. And in his case, it did.
You could keep going.
So there are 3 main types of rhabdomyosarcoma. One of them, and it's a more common one, is the embryonal. So this one can occur the head, neck area, your urinary organs, genital organs, but it can occur anywhere in the body. And for this little girl's case, it was probably embryonal since it was in her head area. Another type is anaplastic. That's the least common, and what Snacks had was actually the alveolar. So this one, it can occur in your extremities, your chest, abdomen, genital organs, or even your anal area. A little bit more about alveolar rhabdo. So this typically affects all age groups equally, but it makes up a larger portion of RMS in older children, teens, and adults. It can again occur in your large muscles of the trunk, your extremities, and alveolar rhabdo tends to grow faster than the embryonal, and it requires a more intense treatment, which for Snacks, he did have a pretty intense treatment because he also went through chemo. So a couple of risk factors, there's not very many, but one of them is age. Like I said, it can happen in adults, but rhabdo is more common in children, and it's slightly more common in boys than it is girls. You find that in cancer, unfortunately, sorry guys, males tend to get cancer more so than females. Another factor, its etiology is pretty much unknown, but it is linked to some inherited conditions. One example, it's called the Beckwith-Wiedemann syndrome. It's also, another name for it is called the overgrowth syndrome. So basically it's a condition that can affect any part of the body. You'll find it in infants when they're born. They're rather large when they're born, and sometimes they'll have one side that's bigger than the other, and also another sign is their tongue will be very large. And here's an example of this little baby. So Snacks's symptoms, he in January of this year, he began having pain. He wasn't eating, and he was very tired all the time. He also began having leg pain, and he was having a really hard time walking. And so his mother took him to urgent care. And because it's not, really a common cancer, and also, he's 12, so they kind of just diagnosed like, oh, he plays basketball. He probably has a pulled muscle. You don't really think cancer. A month later, his symptoms became worse, and he went to UMC, and they did do a CT scan. After that initial CT scan, I'm guessing from what they saw on the image, they were very alarmed. So then that started his workup of tests. So a day after his CT scan, he did a whole body bone scan, followed by a laparotomy, which you can see there. Which you can see there. It's an example of where they usually have the incision, and a biopsy was done as well, followed by cystourethroskopy, which there's an example right there, and then followed by a PET scan of his whole body. The May 13th one, the secondary scan was asked by his oncologist after meeting with him. So his scan showed a very large mass, basically from his diaphragm to his buttocks, and which is why he was in a lot of pain. So the mass was so large that it displaced his bladder, and it also caused a fracture to his pelvis. So that's why he was having a hard time walking, and obviously the little boy was in a lot of pain. With that diagnostic workup that he did, his biopsy revealed on March 4th that he had rhabdomyosarcoma. The PET scan, it showed the mass and some necrosis in his pelvis. So that's when it was decided that he would undergo treatments, chemo and radiation at the same time. Here is his actual scan. As you can see here, this was his mass.
Oh my God.
And it extended, like, you could visually see it every day when we would treat him. You could visually just see, and he's very small for being 12. So you can just, it almost looked like he was a little pregnant. It was insane. And then here is a frontal view. And that's where his pelvis is, so you can have an idea. And this is a transverse view. So on April 16th, he had his consultation with his oncologist. And during that consultation, we come up with a very thorough patient history. So he had no other medical conditions, no surgeries. He was a normal 12-year-old boy, but he does have a family history of cancer. He had a brother who actually died from brainstem cancer. Lives with his mom, siblings. He was a good student, very sweet guy. As far as the chemo that was administered, I don't know what kind of agents were used, but a common agent that they use for rhabdo, they call it a cocktail for chemo, so it was a combination. I'm not even gonna try to pronounce those. But this can give us an idea of some of the chemo that he had. May 21st was his first day of radiation treatment. And this is shows his prescription. So this just says what type of energy was used for our Linac, so 6 MV, and I know Patricia kind of went over what VMAT and IMRT was. He got that kind of treatment, and his total fraction that was given to him was 50.4 gray, 28 fractions, and 1.8 gray a day. So about 5 weeks of treatment. He had no boost, and this just goes over the type of imaging that we did. Some critical organs that were at risk since his treatment site was so huge. There's a couple of organs that were of concern. So his hip, he's still growing. That's very important. And his bladder, rectum, and small bowel. So these organs, like Leslie and Patricia were explaining in their presentation, we want to take these into account for his treatment plan. And with radiation comes the side effects. So depending on what you're treating, depends on what kind of side effects you may be getting. So his treatment site was obviously very large, so everything is in there. Possible side effects can include nausea, vomiting, diarrhea, dysuria, which is just painful urination. Some long-term side effects, it can include secondary cancers, delay in bone growth, and bone abnormalities. For patients who get treatment in this area, it's advised that they take on a low residue diet, which basically just means low fiber. So no raw veggies, raw fruits, stuff with skin, whole grain, you want to avoid those. So more so like white breads and pastas, hot cereals, cooked veggies, stuff like that. And this is an example of his setup every day. He laid on his back, his arms above his head, and he had 2 vac locks, one for his upper and one for his lower extremities. We had to have his pants lowered. We'd give him like a little privacy sheet, and he just had to hold very still. This just kind of goes over what directions the gantry was moving around snacks. Again, this is IMRT, VMAT treatment, and I just kind of wanted to show you what the Linac looks like. So it can actually rotate 360, and the couch can move up and down and around. So it gives us a lot to work with. So a couple of days after his first initial treatment, he's at 720 centigrade. His mother said he's feeling fine, he's eating well, no side effects. About a week after his initial treatment, 10 days after his first treatment, he is responding to the radiation very well, because he already has to be rescanned. And the reason why we do a rescan, if there's any changes, like we're talking centimeters, any changes to, like if he's shrinking, if the tumor is shrinking, or even if the patient's gaining weight, losing weight, we want to re-sim the patient and revise the treatment plan. These plans are extremely precise. You don't want to, and with all the organs involved, it's very important that you don't radiate too much of healthy tissue. June 4th, his tumor has noticeably shrunk, and his mom says he has more energy, he's walking faster, he's playing basketball. At 2,340 centigrade, he's doing well, but the days that he's getting chemo and radiation at the same time, he does get diarrhea, and he doesn't really want to eat because everything tastes gross, he said, and that's probably some side effects from the chemo. And he also has a physical exam. It shows that his mass has shrunk in a few centimeters, and I could actually visually tell that it had shrunk. So he's more than halfway through, still having no problems, no nausea, no vomiting, no diarrhea. Some patients, it just depends. Some patients are more different than others. Some people have no side effects, mild side effects. Some patients can't handle it very well, and sometimes they'll need a break. But he was responding very well to the treatment with no problems. Another week later, he's doing well. He is sleeping a lot. One of the main side effects of radiation that a lot of patients will get is fatigue, so that's normal. And his last day was July 1st, 2019. I did follow up on November. So after he completed the radiation, he was done with us. So I spoke to his radiation nurse, and she said a lot of the times the pediatric patients, they'll get transferred over to another place, in his case, Cure for Kids. And usually when they get transferred over, like, they're kind of like done with us. Like, they have all his medical records and they take care of him. And usually we follow up with our patients a month after they get their radiation treatment. And he didn't end up showing up for his follow-up, but actually a couple weeks ago, I wasn't there, but he came in to say hi to everybody and that he was doing well. At this point, he is getting no more radiation, but he did have 6 more months of chemo. His tumor, again, did shrink, and I asked his doctor what his prognosis was, and he said he's a 50-50 or a 60-40. Given that he did respond well, that's a good sign, but because he is stage 3, he was given a 50-50 chance. And here's just some of my sources. Here.
What's the difference between chemo and radiation therapy?
So chemo can be administered in a couple ways. Like, one is through intravenous, and it's more so throughout the entire body, throughout, like your blood. Radiation, it pinpoints the tumor. Does that make sense?
Yeah.
So when you're getting radiated, the tumor's here, you're not going to radiate the whole body, you're going to radiate this. Chemo is more systemic.
Hopefully it's not too difficult, but can you tell me explain the centigrade or the CGY? Because it was increasing, but like what does that mean? What is that again?
It's our way of talking dosage.
Okay.
That is kind of hard to explain.
So when you're saying that the dosage, because you were having the dates, and as he was getting checked on, it was increasing.
Right.
Was his dosage that he came in and got the radiation or chemotherapy, was the dosage increased each time?
No, so
Okay.
the dosage every day was 1.8 gray,
Oh,
and
okay.
his total dosage was 50
Gotcha.
gray.
Okay.
I'm sorry, I was messing with centigrade and gray.
Okay.
Sorry, it's just metric.
Okay, so that makes sense. So as the days go
Yeah,
on,
so as the days
it
would go
automatically-
on,
it was
yeah.
a total amount.
A
that he
total,
received.
yes,
Okay, cool.
exactly.
Thank you.
Mhm.
So you said with pediatrics, because he still has growing to do. So what's the concern with radiation in growth? Why is that different than, an adult, I guess?
So we want to be careful with pediatrics because they are still growing and sometimes radiation can actually stunt your growth. And it can also weaken the bone and it can cause fractures depending on how much radiation is being given.
So was there, I don't know if you can answer this, but, because I saw on the hip it was 20 gray, and you were giving a higher dose than 20 gray where it could cause hip necrosis. Was that a fear in going in? Was that like one of the possible risks involved?
Yeah, that was on his prescription. I didn't explain the dose volume histogram because Leslie and Patricia did. But on his dose volume histogram, like you could see that was like the limit to his, and because he is a peds patient, I mean that's where your bone marrow is and such, that was of concern. That and a small bowels, because those things are very radiosensitive. So, did that answer that?
You talked about if your patient went to Cure for Kids. Is it a hospital or something where like kids just automatically get to transfer to?
That I'm not sure. That I didn't look into. Yeah, I got that information from his nurse because when I was looking up his documents, like literally when he got his last day of treatment, that was all the medical records he had. Because they just kind of, don't worry about us anymore since I guess Cure for Kids takes care of everything from there on out. But yeah, I can find out.
Thank you.
When you mentioned his diet, did you send them, like refer them to a registered dietitian? Or is it just like a recommendation to the parents?
It's more of a recommendation. It's something that his doctor and the nurse are supposed to go over with him. They do go over the possible side effects, things that he might struggle with through the radiation and also after radiation because the radiation keeps working. But it is something that they will talk about in the first initial meeting. But yeah, it's up to them. I mean, depending on how you want to deal with the radiation. But he didn't seem to have too much of a problem.
So for, in general, raw food is not good for cancer patients?
No, that was just for his treatment. Because we were radiating like his bowels, that it's really hard for patients to deal because it causes diarrhea, nausea, vomiting. If we were, radiating his arm, that wouldn't be of concern. He could eat whatever he wants. That low residue, it's just, if you want to deal with the radiation, like this is what you should do. But no, because we were treating such a large area right here, that's why. But yeah.
Thank you.
Anything else?